Hi, everyone, and welcome to today's webinar, Disrupting the Nursing Shortage, Meet the Virtual Nurse. On behalf of Becker's Healthcare, thank you so much for joining us today. I am pleased to welcome today's speakers. First, we have Scott Shaver, Director of Hospital Information Systems at Memorial Hermann. Next, Mary Ellen Carrillo, Chief Nursing Officer and Vice President of Nursing at Memorial Hermann. Next, we have Jennifer McGuire, Manager of Staffing at Memorial Hermann. And lastly, we have Lizbeth Botruba, Chief Clinical Innovation Officer at Avasure. Thank you all so much for being here today. Lizbeth, I'll now turn the floor over to you.
Thanks, Carly. We're really excited for this webinar today. Because of the nursing shortage crisis, hospital leaders have to update their staffing models. Everyone is looking at new staffing models to meet the demand right now. And virtual nursing is a very promising strategy to add efficiency and effectiveness and support the bedside nurses. There are really three categories of virtual nursing or virtual nursing delivery models that are emerging. The first one is an admission discharge virtual nurse that can really support the documentation process that goes along with admitting and discharging patients in a remote and virtual way to really increase the flow through the hospital, decrease holding times in the emergency department, and shorten that dismissal time. That's one. Another one is the virtual preceptor mentor nurse, which I really love. I hate that phrase when I hear it, that nurses eat their young. And I love the idea that nurses can really nurture and support their young. And virtual nursing is a tremendous way to do that, to really extend the career of some of those more expert, experienced nurses who may no longer be able to meet with the physical demands of bedside care, but just still have so much to add to support novice nurses or new grads in a virtual remote way. And then the last one is what we'll be focusing on today with our colleagues at Memorial Hermann, is more of a remote critical care nurse that really adds that expertise in an efficient, maybe a centralized way across the health system to make sure that that early detection of deterioration occurs, that preventing failure to rescue. So leveraging the expertise of critical care nurses in a central way and a virtual way when so many patients are at high acuity, maybe bordering on critically ill patients housed in step-down units or even med-surg units that really need that extra support to maybe a nurse-to-patient ratio and a layout of the nursing unit that really isn't meant to take care of such critically ill patients. So Memorial Hermann team are really trailblazers here, and they have are going to share today how they stood up a virtual nurse program in the middle of surges of COVID surges, and how that's going to be a sustainable solution as well. So thank you so much for taking the time to share with others what you've learned so people can build on that. And I think Scott Shaver, the Director of Hospital Information Systems, is going to start first. Go ahead, Scott.
Thank you, Elizabeth, and hello, everybody. Thank you for joining us. So just a real quick review of our agenda. Obviously, Elizabeth has already handled the welcomes and introductions. I, as the Director of Hospital Information Systems, will be discussing a little bit of the background of Memorial Hermann itself, our health system, as well as the technical discussion. Jennifer McGuire, who is one of the managers of our central staffing program, will be discussing the staffing component and how we staffed our cameras and the criteria we use to staff those cameras. And then Mary Ellen will be finishing up the discussion with the nursing practice and how it really affected our nurses at the bedside. So just some background information about Memorial Hermann and the Memorial Hermann healthcare system. We have 17 hospitals in the greater Houston Metroplex. Houston is, and Harris County is the third largest county in America. We are a very large, robust metropolitan, very well spread out. You can drive 60 miles and still not get through the entire part of Houston. So we're a really large city. So I always add some some eyebrows, I know, but like I used to drive just to downtown. I drive 30 miles, and I could still drive 30 more miles and still be in what we consider Houston. So we're a big city. We got 17 hospitals. 11 of those are acute care hospitals. We have a children's hospital, an orthopedic specialty hospital, 2 rehab hospitals, and 2 surgical hospitals. We also have 17 convenient care centers, 9 urgent care centers, 4 heart and vascular centers, a neuroscience institute, 6 sports medicine institutes, a trauma institute, and 38 sports medicine and rehab centers across the city of Houston and surrounding areas. We also have ambulatory centers, breast centers, we even have a senior living community that we help manage. We see a little over 665,000 emergency patients annually. We delivered just about a little more half of 26,000 babies a year. We also have our own air ambulance service. We are actually the oldest hospital air ambulance program in the United States. We're the second oldest just in general. The only other one is a publicly funded one, I believe out of Maine, but we're the oldest hospital-based program and have been flying missions for 45 years in the Houston area with our air ambulance system here in Houston. And we do right around 3,400 air ambulance missions every year. We have over 28,000 employees in our system. We have 43,886 licensed beds, and we have an annual community benefit of $525 million. We're also affiliated with the McGovern Medical School at the University of Texas Health Science Center in Houston. We have a level 1 trauma center, several level 1 stroke centers, level 2 trauma centers. So we basically do just about everything you can think of in healthcare. I think I'm not sure what else we can do. We have it everywhere. So we are very much involved in the care and well-being of our city here in Houston, Texas. I want to discuss 2 trends with you, two of our surges. Our first really major surge was the summer of 2020. Feels like a lifetime ago, but it's really only a year and a half ago. So August 2020, September 2020 was really our first major surge we saw in the Houston area. For those of you that don't know, it gets hot in Houston. And when it gets hot in Houston, we all stay inside. So that's one of the reasons why a lot of people believe why we have our summer surges is because we're all inside, because it's just too dang hot to be outside. So we saw our first major surge in August 2020 to September 2020. And our pilot really first started that summer. We started right on the same time as that surge started. Really, it was really just getting our feet wet, getting the cameras up and running, and really trying to map out how we would do this, because really, as far as we could tell, no one else had done what we were doing, which was to using our Avasure cameras to watch COVID patients. And so we really kind of just have a bunch of people get together and try to figure out how we could use this to make our patients safer. So really, our first surge was really just getting our feet wet, kind of setting up stuff and understanding. But as you can see, we trended down greatly in those 2 months, and really we stopped that pilot after the first month and a half because we just didn't have a need for it with our patient volume. But then January 2021 through March 2021, our second surge hit, and this is really when we started really using the cameras a lot. You can see we got up over 25,000 in the Houston area. This is actually the Houston-Harris County area, so we saw a lot of COVID patients. And so we really started using our cameras then for a lot. And then we had yet another summer surge this past 2021. And again, our cameras came into full play then. I always like to start off with a problem statement. So especially in IT, we always, a lot of times we get people come up with a solution already, but they can't identify what the problem is they're actually trying to solve. So we always take a step back, let's define the problem, and then let's try to find a solution that meets the problem you're actually identifying. So our problem statement for this was really that ICU patients are typically admitted in rooms designed for ICU patients. I know that's shocking, but that's how it works, right? These rooms typically have all glass walls or glass doors, so that even with the door closed, or even a good-sized window, even with the door closed and negative pressure perhaps being done, a nurse can still maintain a visual on her patient or his patient at all times. And so that did not happen with our patients, because once our ICUs got filled up, Well, guess what? We had to put patients in non-ICU beds, even though they're still ICU patients. So we converted many of our IMUs, we converted PACUs, we converted anything that we could put a COVID patient into, we converted to an ICU room, and we're been housing patients in these rooms. And one of the first two things we noticed, one, we lost line of sight of our patients, and the only way we could do it would be to open the door. And with COVID, when you crack the door, you gotta be in full PPE. So we really lost that line of sight, that visual on our patients. And as a nurse myself, I can attest that a lot can be assessed by a patient and how they're doing just by looking at them. I mean, granted, yeah, full assessment, etc., but I can look at the patient and go, oh yeah, something squirrely is going on, I need to check on them. And we lost that ability with these solid doors and solid walled rooms we had to convert to ICU. So we had to come up with a solution that met the need of being able to get a visual, a line of sight back on these patients without having to have an open door or breaking that negative pressure room or donning full PPE just to go check on a patient. So our solution involved technology, a technology change, a staffing change, and a nurse practice change. So what this is just a quick timeline, and I just highlight this because it was a rapid ramp up. I have been in IT for 7 years, and then with Memorial Hermann for just over 20 years, first as a nurse and now as an IT. And we're like a giant ship, like a giant cruise ship, and that we can't spend on a dime for the most part. But when we have to, and we did. We did a rapid ramp up of these cameras and these policy changes and these nursing changes and these practice changes, and got our initial pilot up really, really fast for us. And we even did some work from home pilots where, and we'll kind of get in this later on, I think Jennifer has some touching points on this, so we actually had nurses able to work from home remotely and watch our patients. So we did a lot of rapid stuff for our timelines. So just to quickly talk about our Avasure pre-COVID state, we've been with Avasure for quite a while in the telesitter space, using the cameras and telesitters to virtually watch patients who needed a sitter. So we had close to 200 cameras deployed across our enterprise at 12 of our acute facilities. These cameras were primarily being used for sitters. Each facility, because we were on an older version of Avasure, and one of the actual benefits of us doing this pilot we did is we actually were able to go to a centralized server, which will benefit from greatly going forward. But up until that point in time, we honestly didn't have the need. We were working fine the way it was. So we had a dedicated server for each camera monitoring station set up per campus. So if my Southeast campus wanted to watch patients, they could only watch patients at Southeast. They couldn't, for example, watch it at Northeast or Southwest or my TMC campus. And so that was the way to change very quickly and move to a centralized server model, spoken hub model for a server to where we can watch patients across the enterprise from a centralized location. Each facility actually staffed their own monitoring techs. It was all decentralized, run by the campus, paid for by the campus, everything ran by the campus. And so each campus, as you can imagine, may have had a different process for contacting and ordering that remote visual monitoring. So these are some of the challenges that we had to overcome pre-COVID because they would not work in this new world order we had for our cameras. So deployment also took some time. So getting these cameras in from Avasure, getting them out to the campuses, getting assembled. For us, for the way Memorial Hermann does things, it involves three different teams to really get the camera from being in the box to being ready to put into a patient's room. It involved my clinical engineering department helping to assemble the devices, making sure they were good to go in our environment. My information systems department making sure we had proper networking done and make sure they're all working right. The nursing operations to not only understand how to use the camera, because there is a right way and a wrong way to put a camera in a room to see what you want to see, but also just understand also where they're going to be stored at when they're not being used, and have some consistency in that. Camera testing, each camera was tested individually before we actually use it on a patient. We went through a full diagnostic internally and then make sure it works. We'd have one of my people who are experts at using cameras sit down and use it and run through all its paces to be sure the camera was working the way it was supposed to. Workstation configurations and testing. So we had to set up 20 different workstations in a central location for my monitoring nurses to be able to monitor patients. So we just set up all those devices. Memorial Hermann is a virtual desktop or a VDI shop, meaning when I log into my computer at work, I'm actually logging into a virtual desktop, not the real computer. However, Avasure has to be on a real computer. So we had to come up with a whole new, we'll call it an image, a whole new image on our computers to where I had one screen that was the virtual desktop, so the nurses could look into our Cerner power chart and to see where, look at charting, but also see on the other screen the local desktop where Avasure sat. So we had to do some configuration and testing there. Our initial pilot for that very first surge, just to kind of work some of the kinks out, involved a couple of what would become my super users, as well as my own internal clinical informaticists who worked on workflows and assisted with policy and procedure writing. Final configuration, we now have a 14 server cluster in my data center that manages all my cameras across the enterprise. At the time, we had 17 individual rooms. We chose 17 because we looked at how many patients we felt each nurse could watch safely. And this is different for organization and for what you're doing, but for us, for COVID patients, and for what we're asking them to do, we decided that the max was going to be 8 at the max. Oftentimes it was less, but simple math, we needed 17 rooms to watch all the cameras we had deployed for COVID. We also had multiple parts of my own ISD, my information systems division, involved in this whole thing, as I mentioned before. And then again, the software components, Avasure, Thick Client, so for those of you who aren't in IT, Thick Client means installed locally on the device, whereas the VMware client, which is a virtual desktop, that's where the nurses Outlook. We actually use Zoom for our communication. There was a channel set up for all the nurses so that we could talk back and forth, not only with themselves, but with all the IT folks who were helping support them, so we could have real-time conversations on that Zoom chat channel. And then again, the Cerner power chart for them to look up patients and look up information on the patients. And then we did some different training modules. Avasure has their own online training module that they use all the telesitters with. We actually use that with our nurses to give them a really good base understanding of how to use the camera and how to use the Avasure client. And then we also did our own train the trainer and super users on how to actually then take that training and apply it to looking and working on patients who are COVID positive. We had 100 cameras deployed across our enterprise specifically for COVID patient monitoring. Again, 17 workstations. On the right there, you see the campuses that we used. Those are all my acute care facilities and how many cameras each campus had. Basically, when we decided to do this, we went to all the CNOs and said, okay, guys, we got 100 cameras. How do you want us to disperse them from an operational standpoint? And of course, each wanted 100. So I said, no, they can't all have 100. So they came down with some great numbers. We all dispersed them throughout our enterprise. And what's fun, to me, which is interesting, is some of my biggest campuses had smaller camera requests. And that's actually because as an organization, we made a decision back when COVID first started that we were not going to oversaturate as much as possible our big hospitals with COVID patients, because my big hospitals tend to be a level 1 trauma center, a level 2 trauma center. And we got to we have to have room for just other patients, right, other than COVID. So a lot of our community hospitals, which may not have the same number of beds per se, had a lot more COVID patients because they were being used to have those patients there. So some of my smaller campuses had the biggest numbers of cameras for the COVID monitoring program. We also did a remote deployment. So this is what I talked about earlier about having nurses working from home. We had a few nurses who we call being on accommodation. So for whatever reason, they could not work in a hospital, but they could work from home. One example was we had a nurse who broke his ankle. Can't work in the hospital when you got a broke ankle, but I can sure as shoot and put you in a chair at your house and give you a setup, and you can work from home and watch patients. So even though in a traditional world pre-COVID, he would have been out on leave probably on short-term disability, but because he was able to do this, he was able to work from home. And so we had to come up with a whole plan of how to not only package and ship an entire setup to their house to use, but also how to get it back to us and clean it properly because again, COVID, everything was getting cleaned extra carefully. So my desktop and my client management teams here at Hermann came up with this red bin and this package set up, and we had basically a hotshot driver who would deliver it to the person's house in this crate, and then when they were done with if they were done, come pick it back up, and then it would be brought back to us in a controlled environment where it would be cleaned, repackaged to be available for somebody else. So this was really beneficial, I think, because we had several nurses physically who work from home. We also, in the future, could use it for nurses who are maybe mentally not able to work more than 3 shifts. I have full disclosure. I guarantee you, if I was a nurse on the floor right now, I would do 3 shifts and that would be it. I am too old to do more than that. When I was younger, I'd do 4 and 5 shifts a week because I was young and crazy, right? Not no more. My body doesn't work that way no more. But I can guarantee you, I could do 3 shifts in my ER and then do a shift at home doing this. I could definitely do that. And so we actually have that availability as well, not just for COVID, but for really anything in the future, right? This can be applied to really anything that we can think of in the future where we can use virtual nursing to take care of patients. That is my time. So I am now going to turn it over to Jennifer McGuire, our manager for central staffing, for the staffing discussion.
Hi, good afternoon, everyone. Before I get into our staffing operations, I think it's important just to talk about who we are as a department within Memorial Hermann and our purpose. And then we'll get into the good stuff, the staffing. So within central staffing, what we refer to as our admin group, we have the staffing team. We have an HR department, we have education and training who takes care of all of our nurses, education, continuous education, new hire orientation training, annual compliance, any credentialing documents. And then we have our own recruiters that recruit for central staffing. We have a payroll team, and then we also have a team that supports external agency as well. And then within central staffing, we have about 1,000 employees that supports the system across the Houston area. And so of that group, about 500 are RNs, and the other 500 make up anywhere from our PCAs or RCPs. We have medical assistants, PARs, physical therapy, occupational therapy, office assistants, and newly with COVID, we also staff screeners throughout the system. And so with that very brief overview of our department, this is where we started and launched the pilot with Southeast. We pulled 14 nurses, 14 ICU nurses, and kicked off the Avasure pilot with our Southeast group. Next slide, Scott. And so as the program evolved, you know, a surge is a surge, but I think it's important as we looked back, each surge was very different and unique in its own way. And so when we first kicked off the pilot, we had, as Scott mentioned, we had employees that system-wide that were on accommodations that were able to support us through this process. And so we created a process to where if Southwest or Northeast had that employee that was able to help support this project, we had to make sure the nurse had the qualifications. And then we also had to just map out a process as to how to get that employee in touch with us so we could set them up and make sure they had all the training and education that was necessary. And then as Scott mentioned, through the second surge, we did set up the remote requirements at home, what the expectations was. You know, you had to have a stable internet, how to activate your Avasure monitor, how to set it up. And then we also created during the second surge was an end of shift report. And so with this end of shift report, it was a very high level report that covered, you know, if they had any technical issues throughout their shift, any quality concerns with the patients, what the current census was, and then if we had any patients that were waiting in our queue, waiting to be monitored within Avasure. And then prior to our third surge, We looked at all of our training guides. We got our clinical education team involved, and they really enhanced the training and education resources for this program. You had different managers that would come in and they hadn't had to activate a camera before. So having our monitor nurses be able to walk them through that process, how to set up the camera, make sure it's the right camera, and just those guides and then just guides and expectations of what a monitor nurse was to do, and then what obviously the bedside nurse was expected to do as well, and how they collaborated through that shift together. Next slide, Scott. So this is where I get into the breakdown of the dates of the surges. And like I said, through these 3 surges, everyone was very different from a staffing lens. And so we launched the program, and we started with just Southeast and then eventually brought on Northeast and Greater Heights. I mentioned we had 14 ICU nurses, and we had 2 nurses work per shift. So 2 nurses, 7A, 7P, 2 nurses, 7P, 7A, and all of our nurses were on site at Memorial City. Starting with the second surge, we also threw in the Houston freeze, which, Scott mentioned we have hot weather. Well, we have no idea how to act when there's snow and ice on the grounds. So that's when we kicked in. Okay, we don't want our nurses traveling. They can work from home. We set up the remote home computers. And so we still managed to staff 14 ICU nurses, 2 days and 2 nights. And so some of them actually did stay on site, but we did have a group of them at home. And that definitely brought some challenges. We had electricity issues, and this was definitely a lesson learned and something that we did different in our third surge. And it was who had power at the moment. And the nurses had to flip back and forth and cover for each other because electricity would go out. And we had to get somebody else who had electricity at the time to make sure they were able to cover their patients. And we were still able to monitor those and see the patients. So moving on to our third surge, staffing was a bit different and much more challenging to ramp up. We really wanted to try to get to 3 nurses per shift rather than the 2 that we did in the previous surges. We were able to start with 7 nurses. Again, 2 nurses our goal was 2 nurses per shift, and then to ramp up to 3. And this was different because you have more what I call agency temptations, and that's still happening currently. Is, we have a lot of resignations and employees going to work for agencies. We offered increased bonuses, and it was a very, very tough time to get more nurses to work. And not only that, it was just burnout. They were exhausted from, the previous surges. And, we offered a very, very incentive bonus to get them to work, but it was definitely a challenge. And we were only able to stick with the 2 nurses. We weren't able to build up to 3 for this last go round. And so that's where we are. We still currently are monitoring a few patients, but of course, thankfully, we are not surging right now, but we still are supporting the hospitals and have some active cameras out there. But it's not to where, when we're high surging to where we're wanting 3 to 2 nurses per shift. All right, I'm going to hand it over to Mary Ellen.
Thank you, Jennifer. So I will go over a little bit more about the nursing practice and some lessons learned and just some barriers that we saw as well. So as you can only imagine, during these various surges, one of the things that we saw significantly increase in each of our surges was our critical care volume. In each of them definitely doubled during each surge, but even this last one tripled in many of our campuses. I know my own campus went, we extended into several different areas. filled up our PACU, filled up our IMCU with ICU. And that was very similar at many of our hospitals, sister hospitals. One of the biggest challenges was how do we staff these critical care patients that are COVID, that are much more acutely sick than we've ever seen in the past, with the same amount of staff, sometimes even less, just because some of the shortages that Jennifer spoke to earlier. And so we really had to get creative, and using our Avasure model was definitely one of the opportunities that we took full advantage of. We did have to come up with some various criteria and so forth, because as you can only imagine, there was a great need for these cameras, given that. But it allowed us to utilize team nursing a lot better. And then we also had additional support staff. As you can only imagine, at the beginning of the pandemic, most organizations brought down their surgeries. And so we had all this surgery staff that were clinical licensed staff that we could utilize, but didn't necessarily have the right skill set to take care of the critical care patients. And so this allowed us to use the team nursing approach while still having some critical care eyes and expertise viewing the patients as a safety net. And so that's what we utilize. Scott mentioned earlier in the presentation that we went to utilizing rooms without any true visibility of these patients. And that truly caused a lot of heartburn for our nurses who truly needed to see these patients. These COVID patients were declining very quickly, and many times needed interventions more rapidly than normal. And so having that visibility was very vital in keeping our patients safe. And so we utilize these patients in these key areas where there was a lack of visibility, not necessarily just in our main ICUs that had that visibility, but we use them on the offsite areas where our nurses couldn't see their patients, they couldn't hear their patients. So we had that safety net of that expertise looking through those cameras, watching those patients 24/7. One of the areas that we found, and it was quite interesting, we didn't realize that staff buy-in was truly going to be an area that we were going to have to overcome. Nurses at the very beginning of the pilot felt like the big brother was watching over them, and they weren't necessarily fond of the monitors. And so we had to build that trust. And then the nurses that were looking through the monitors, these weren't their coworkers that they worked side by side on a daily basis and already had that relationship and trust built. So we had to work on building that trust, building that relationship, increasing communication. Scott and his team added some visibility features through Zoom features so that they could actually see each other and have conversations to build that trust. But it was definitely an opportunity that we found early on that we had to overcome, because we knew at the end of the day, if we didn't build that trust at the very beginning, we were not going to be successful in this program. And so that was definitely an area that we really focused on. Education gap as well. Jennifer alluded to a lot of staffing challenges that we had to navigate during this pandemic, and utilizing not just nurses from procedural areas, but nurses from some of our office type work that have clinical background by trade, but haven't been at the bedside for years. And so how do we staff them up, skill them up to be able to provide that expertise at the bedside that we so desperately need through this virtual monitoring? And so Jennifer and her team worked very quickly to build education modules and to be able to skill these individuals up to be able to provide that service. And that was something that was very crucial during this time as well. Also, just some of the other education opportunity was making sure that not only that our monitor nurses knew exactly what needed to be done, but also our frontline had a good understanding as what was the expectation, what was the process, what should their expectations be from the monitor nurse and vice versa. Then also our leadership needed to know, because we have after hours, and what did that escalation process look like? So a lot of education all the way around. We first started with just focusing on the monitor nurses and quickly realized there are a lot of stakeholders at the table that we had to get in front of. Next slide, please. And so this is just a quick overview of some of the areas that we really focused on through the monitor nurse program. It was definitely our critical care patients that we focused on. And we looked at being able to monitor those physiological monitors that the nurses were either stretched from a staffing assignment or from a visibility assignment, couldn't see those monitors on a continuous basis. Medical devices, whether that was an art line or a ventilator, whatever that looked like, making sure that somebody was focused on those medical devices as well. Then making sure, because we couldn't have the, again, we didn't have that visibility, validating that we're watching patients who could be potential for self-extubation and getting in front of that quickly. Of course, safety was always top of mind, looking for fall risk, looking at patients who might be pulling at their lines, and then IV medications. During this time when we were trying to limit nurses entering the rooms and still keep our patients safe, having somebody being able to monitor those bags to make sure that they weren't dry, and then also monitoring those cardiac drips that were so sensitive and needed somebody in there quickly if the pump was beeping, or again, if there needed to be any change to that. So these were definitely our focus areas that the nurses monitored and that were truly key to the success of keeping our patients safe. Next slide, please. And so just some more lessons learned. We definitely identified communication is key. We realized early on that if that communication was not there, there were breakdowns, whether that was somebody not realizing that a patient needed to be monitored for specific concerns, or maybe things weren't escalated or shared shift to shift. So communication was definitely key. We built in a lot of different safety nets around communication just to ensure that that occurred. Then we also realized that on top of just the normal items that we shared on the prior slide that the monitor nurse would look at, we wanted to make sure that whatever the nurse was concerned about at that particular moment or shift, that the monitor nurse was also focused on that. So we asked the nurse to provide the top 3 areas of concern that they had for that patient for that shift in that day, so that the monitor nurse could be aware of that and look at that. Then also the need for escalation. As we shared earlier, during this time, our nurses were stretched. And so it was hard to catch somebody exactly when you needed them, especially if you needed help, whether that patient was needing somebody to go into the room immediately. And so we built in escalation processes. So if they weren't able to get that bedside nurse, they were able to get that charge nurse or the next level of escalation to ensure that at the end of the day, somebody was able to go in and assess the patient. Then we also created a triage process because once we implemented this, the need grew quickly. And so we had to formalize criteria and then a triage process to ensure that we were always looking at those patients that were highest risk for monitoring purposes. And then creating that pipeline for staffing support, which is honestly has been probably one of the biggest challenges, given the fact that we really needed our ICU nurses at the bedside, taking care of our ICU patients. And so how do we create that pipeline and still staff our bedside and still provide the additional support we needed as our staffing was definitely stretched. So just some opportunities that we learned. And again, Jennifer shared a lot of the work that she did around that. But at the end of the day, it was a lot of success, definitely growth. But at the end of the day, we were able to keep our patients much safer during the pandemic. And Elizabeth, I'll turn it back over to you.
Yeah, thank you so much. This is fascinating. A couple questions that come in my mind. One is you talked about how this has supported team nursing. So have you made a shift from primary nursing towards team nursing during the last couple of years, A, and then B, if more specifically, if the virtual nurse is watching up to 8 patients, how many bedside nurses is he or she then supporting? Like, how does that team look?
Yeah, it's a great question. It did look different on every one of our campuses. Now, we don't typically use a team nursing model, but during the pandemic, we had to do that because of the increase in our critical care patients. So we did have some of our med-surg, some of our procedural areas partnered with our critical care nurses so that they could share some of that workload so that we could still provide that safe care. Though we realize that going into the future of nursing, we are still having to look at various models of nursing, knowing that with the nurse shortages that we're facing, that we're going to have to really focus on virtual nursing as a greater component of our staffing models. And so team nursing definitely looked different. It looked in the ICU anywhere from typically 3 to 4 patients to a group of nurses, typically an ICU nurse and an IMCU nurse teamed together, or maybe even a procedural nurse and a med surg with that ICU nurse. We definitely try to keep it safe, but the ratios definitely increased for the ICU level nurse. So we supplemented that with either task nurses or team nursing approach.
So maybe this is for Jennifer and Mary. Was there a kind of a huddle or group pod report at the beginning to say these are the top 3 areas, and the recovery room nurse is going to do these skills or tasks, while the I'm just imagining that's a completely different way to deliver care, and I can see how there might have been confusion and gray areas and the danger of missing things or overlapping.
Yeah, I can definitely take that and then defer to Jennifer for any additional information. So early on, when we first started the pandemic, we realized that staffing was definitely going to be a challenge and that we would most likely have to move into team nursing. Though we prayed we wouldn't have to, we realized it would definitely we would need to be prepared. And so our system education team went quickly into creating education on team nursing, identifying what the roles would be if you worked in an ICU setting in team nurse or in a med surg area. And so really looked at that. They also developed system-wide education for scaling up these nurses and even our PCAs, so that our PCAs can learn how to draw blood and start IVs and so forth. And so we got in front of that pretty quickly at the very beginning of the pandemic. And so we had templates already built, forms already built, so that once we had to actually deploy it, it was much easier, and the staff were already prepared for that.
Yeah, and I'll just add, I know the nurse had shared with me that the end of the shift report form that we initially created, that's something that they looked at together, at shift change, to review the top 3 things that they wanted to watch out for this patient. And that's something that Scott's team, he created as well. When the hospital needs to request to add someone to Avasure, they had to list the top 3 things that the monitor nurse wanted the monitor nurse to focus on this specific patient. And then so at shift change, the 2 nurses would exchange, the information kind of like they would do if they were bedside nurses. And so that was helpful because some things we did learn that, it would get missed. And so that report really did capture all those different things. And even to, if there was technical issues with the camera, this camera has been flashing for whatever reason. And if it flashes, we're aware and they're working on it. And it was really good to have for them to share that information with each other, especially when we were remote, because when we first started, everybody was at Memorial City. And so they were socially distancing, but they could still kind of yell across the room at each other. And so when they went remote, they didn't have that luxury, so to speak. So it was very different. And so the end of shift report form really came in handy as well.
And Elizabeth, I'll also add, we actually also, of course, encouraged our tele-nurses to call the bedside nurses at the beginning of each shift to introduce themselves, and then maybe even refine the top 3 things they're looking for, because patients change, right? So we always encourage them. We usually we tell them to do it, after our shift change here and is at 7A and 7P. So we always say, hey, probably wait till about 8 o'clock, P and A and P to call, so that way they have a chance to get their report and get ready and just kind of introduce yourself and let them know, what's going on. And then just wanted to kind of bounce off one of the things Jennifer said too about, cameras flashing or freezing. I always say the best way to test your Wi-Fi network is to use Avasure, because it will really make sure your Wi-Fi is robust and can handle it, because it is a continuous 24/7 video feed. And I'm not saying this like meanly, it's how it's supposed to be, right? And so we were actually able to identify some areas where, you know what, I need to beef up my Wi-Fi in this area.
Yeah.
Because once his cameras are behind his closed door, you know, maybe my access point is 6 feet from the door. Well, maybe I need to get another access point closer or move it because my Wi-Fi signal in that room is causing a disruption in my video feed. So these are things that, from the IT standpoint, to think about too when deploying cameras. Now, Avasure does have, I call them plug-in cameras. You actually plug into your ports, but long time ago in a valley far, far away, Hermann made the decision that we're just going to do Wi-Fi because it was just much more convenient.
Yeah.
But it definitely showed us where we needed to beef up our Wi-Fi networks, which we still do. To even outside of the COVID project, just in general, we still find areas where I need to beef up my Wi-Fi network because, you know, the signal just isn't as great as it should be. So those are some of the challenges we faced.
And Scott, I wrote down a question for you too. While you were talking, you were saying, you know, we're a big ship that doesn't turn on a dime. And so I'm wondering if moving into the next 5-10 years, if you have maybe learned more or gotten more confidence that, hey, we can implement things faster than we used to. And maybe, so have you learned things that you will apply into the future during these last couple of years?
Well, what I find is we can make changes rapidly when the fire's hot enough. And so definitely the fire was hot enough, but you know, one of the things about being a really large healthcare system is we have councils, physician councils, nursing councils, critical care councils, individual facilities. So, and we try to look at things at a system level to try to make things consistent throughout the entire enterprise. And so when one campus has a great idea, it takes time to get everybody to agree to that great idea and then put the change into effect. And then on top of that, ISD is always busy. We're like nurses. We never have a, you know, we never have a downtime, right? So where do you put that great idea in the line of other great ideas to get implemented, right? So, like I said, I think we learned that, especially if we are familiar with the technology, we can make rapid adjustments as needed, so we can be very agile in that case. But obviously, with new stuff still takes, like if I brought in a whole new solution and we'd never used it before, it's going to take time because we're going to vet it, make sure it works the way we want it to, and so forth. But I think we learned some lessons. And I do think I may hold the record right now with the fastest implementation of a technology from Hermann, because it literally was like in a 2-week period, we went from not having cameras to having them across the entire enterprise and watching patients with nurses watching it. So we can do it when we have to. And I think that's one thing we feel good about is if, you know, when the fire is hot, we can make the changes that need to happen quickly. And then we just take some time, sometimes on the back end, to do other stuff we're normally doing on the front end, if that makes sense.
Elizabeth, just to add, we definitely realize that being nimble as an organization is important as we move into the future. And so we have built in some processes even going forward. Scott alluded to the fact that we're really trying to make sure that we're standardized across our organization, which is also very helpful in many respects because it's easier to make changes and when everybody's standardized. So we've really moved towards that. But then also, and I know Scott alluded to this as well, is that we have radical prioritization processes, so that we have key senior leaders in our organization who we can get in front of, who, when we need to make changes quickly, can help guide those changes and really support those. And so they've definitely, we've definitely implemented a lot of change, given the fact that as an organization as large as we are, we have to be able to be nimble when it counts, right? At the same time, we want to be thorough when it is important for our patients and their safety. So a lot of lessons learned around that as well. I think it's something that every organization continues to navigate, trying to be nimble enough to work through those process flows. But we've definitely learned, and Scott's right, we definitely learned how to do it quickly during the pandemic.
Did you say radical prioritization?
So that's our internal process. It's just basically, for a long time previous, probably up until about a year ago, if somebody had a great idea for IT stuff, it just got brought in, and we looked at it and would commit a lot of resources up front to investigating it. About a year ago, we put in a new process to where any new IT thing has to go through what we call radical prioritization, which involves discovery, or define phase, a discovery phase, and then an execution phase. But a lot of that work we used to do in the front end now doesn't, because what would happen is we do all this front end work and then realize that doesn't fit our model for our system. So we realized we really need to put all this work after we decide if it's going to be something for our system. So now a senior level VP, so we have VPs, we have SVPs, we have EVPs, right? So now a senior level VP and SVP or higher has to approve the project before we even, from an IT standpoint, start digging into it deeply. And so we have a whole process now where it's a submission process and getting the appropriate senior leadership to approve it depending on what service line or campus it's at, and then putting it in line with other projects to see where we're going to go with it. So, but we call it radical prioritization because for us, it was a radical change of the previous way we did things.
Yeah, that makes a lot of sense. So I think we're out of time. I have like more questions I could ask, but we are out of time. And this has been very enlightening. And thank you what you're doing to keep your patients safe and support your bedside nurses, because I know bedside nurses in that situation could really feel lonely on an island, and to have this additional resource for them is truly a gift. So thank you for doing that. And thank you for sharing this afternoon.
It's a pleasure.
Having us. Thank you.
Yeah.
Thank you.
That is all the time we have for today. I want to thank our presenters from Memorial Hermann, and I also want to thank Avasure for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section in your webinar console. Thank you for joining us and have a wonderful day.